Dr. Rohan, can we start our program?
Yes, ma'am, done.
Okay.
Am I audible?
Yes, you are audible. Over to President Neboy to start the classroom officially.
Good evening, everybody. Today is our another classroom program, and we are welcoming our guest, Dr. Pralada from Chitradurga, Karnataka, our speaker, Dr. Suklima, and Dr. what is the
Dr.
Doctor-
Suklima is the speaker, yes.
speaker? One.
Only.
And the moderator, Dr. B.N. Sharma from Guwahati, and Dr. Biplab Pal from Tripura. So I do welcome you all. I welcome everybody to join in this program. It will be definitely helpful to everybody. So especially I welcome Dr. Pralada. Thank you. Thank you very much. Next.
Yes, Anjanava. Hello.
Yeah. Can you introduce our guest faculty today? Anjan?
Yes. I welcome everyone who have joined here for the Nebai classroom. So we have been running this Nebai classroom since January. So here in the classroom, most of the ENT fraternity from the Northeast Association have been joining for these academic events, and along with we are inviting one of the national faculty in this program. So today with us he is Dr. Pralada. He is known for his work in all over India and abroad. So I would like to give you a brief bio from Dr. Pralada. He is presently working as a senior professor of ENT and head and neck surgery at Basaveshwara Medical College and Hospital, Chitradurga, Karnataka. He did his master's from PGI Chandigarh, and he is also an MBA in hospital and healthcare management from BITS Pilani. So he published his pioneer books on imaging for endoscopic sinus surgery. In the year 2000, he was awarded Dr. RAF Upar National Award for his original surgical technique. We know that is the Karnataka flap for master obliteration technique. Most of us we know about the Karnataka flap. So Dr. Pralada presented and published many original research articles, developed original treatment and surgical techniques, and has won more than 18 prestigious gold medals for his research activities. He was awarded with the Best Research Award in 2022 by the Karnataka AY chapter. As a research person, he has delivered lectures, shared sessions, and demonstrated various surgeries in more than 500 national and international courses and conferences. He has trained more than 120 junior ENT surgeons from India as well as abroad. He has produced many educational CD and DVD to teach ENT fraternity. He is also a chief scientific advisor to one of the Fortune 500 company, those developing innovative medical technology products. So this is a very brief of Dr. Pralada. There is a long list, so it will take a lot of time. I welcome Dr. Pralada for our Nebai academic sessions. I hope everyone will be very much benefited with your insights in this particular subject. Thanks for coming, sir.
Yeah.
And now over to Chairman Scientific Committee, Dr. Swagata Khanna, to introduce our moderators and the speaker for this session.
Thank you very much, Dr. Anjana, and everyone. Welcome to this Nebai classroom. I would like to introduce our today's speaker, Dr. Suklima Sengupta. She pursued her MBBS from North Bengal Medical College and Hospital, Darjeeling, West Bengal, currently undergoing post-graduation in ENT and head and neck surgery at Silchar Medical College, Assam. She has been awarded the prestigious Dr. S.N. Sharma Award for the best scientific paper at 35th Annual Conference of Northeast Branch of Association of Otolaryngologists of India in 2024 at Shivsagar, Assam. She has publication in International Journal of Otorhinolaryngology and Head and Neck Surgery and also in Indian Journal of Research. Regarding our chairperson, both esteemed chairperson, Sir Dr. B.N. Sharma, he did his graduation and post-graduation from Assam Medical College, Dibrugarh, Assam. Previously, he worked as an ENT specialist in Iran, presently working as senior consultant at Dispur Hospital, Guwahati. He was the past president of AOI Guwahati chapter, presently elected as vice president of Northeast Branch of Association of Otolaryngologists of India. Regarding Dr. Biplab Nath, he is the present professor and head of the Department of ENT and Head and Neck Surgery at Agartala Government Medical College, Tripura. Worked at various teaching institutes, having been interested in otology and skull-based surgery, took active part in training of postgraduate students, conducted numerous CME program, surgical workshop, and he has some publication in his credit in various national and international journals. So this is a very brief biodata of our chairperson. So without much delay, I welcome Dr. Suklima Sengupta to present her, to deliver her lecture.
Thank you, ma'am. Good evening, respected teachers and everyone present here. I grabbed the opportunity to thank you, Nebai organizing team and my professors to give me this opportunity to present this in front of all eminent faculties. And I sincerely send regards to every one of you and apologies for any mistakes. So I am Dr. Suklima Sengupta, and today's topic of presentation is anatomy of facial nerve and its surgical importance. So I want everyone to look at this picture. This is a beautiful drawing and with a very strong expression. And we all know this expression comes from the facial muscles. And these facial muscles can only function well when we have a flawless facial nerve. And as an ENT surgeon, when we all do various surgeries like ear surgeries, mastoid surgeries, parotids, even skull-based surgeries, the facial nerve plays a very crucial role in each one of them. And none of us want that after doing a precise and successful surgery, when we go to the post-op rounds to see a cosmetic deformity in our patients. So the anatomy of facial nerve is very, very important for all of us and beginners like us to know the very critical points about the anatomy. Thereby, I start my presentation. So today's topic of discussions will be first, anatomy of facial nerve. Second, the pathophysiology of the facial nerve. Third, evaluation of facial nerve functions. Fourth, common diseases of facial nerve. And last, the surgical importances. So coming to the introduction, the facial nerve, we all know, is the seventh cranial nerve, also called as the queen of the face because it controls all the muscles of facial expression. It is a mixed nerve which has a motor and sensory roots. The sensory part is the thinner, which is nervus intermedius, and the motor is the thicker, which is facial nerve proper. It is a branch from the second branchial arc, and it contains around 7,000 to 10,000 fibers. Before we go to the anatomy, let us see this image. This is a sagittal section where we can see this is the pons, this is the medulla, and this is the cerebellum. And our facial nerve exits through this pontomedullary junction. If we see from the anterior view, this is the midbrain, this is the pons and the medulla, the facial nerve exiting along with the vestibulo-ocular nerve. Now, when we take a section, then we get to know about the various nuclei of the facial nerve. So first, this blue structure, which is the main, that is a motor nucleus, which is in the caudal pons, also called as the facial nucleus. Now the fibers from this nucleus, generally all the motor fibers runs anteriorly, but these fibers do not run anteriorly. They go posteriorly, loop around one nerve, that is the abducens nerve, and then it goes anteriorly and exits. Now, since it makes a loop around this, it creates an elevation over the base of the fourth ventricle called as the facial colliculus. If this is the base of the fourth ventricle, and this is the facial colliculus, and elevation formed, which is very important during surgeries. Apart from there are three other nuclei. The one is, this is the superior salivatory or the lacrimetal nucleus. Then there is the nucleus of Tractus solitarius, which contains cranial nerve 9 and 10 and extends till medulla oblongata. And this is the spinal nucleus or the trigeminal nucleus. Next, coming to the functional components of the nerve, special visceral efferents are the branchial motor fibers, which supplies the muscles of the facial expression. Next is the general visceral efferents, which is the parasympathetic or preganglionic secretomotor fibers, which supplies the lacrimal glands, salivary glands, and the submandibular glands arising from the salivary and lacrimatory nucleus. The next is the special visceral afferents, which are the gustatory fibers, which carries the taste sensation from the tongue and goes to the nucleus tractus solitarius, that is 7, 9, and 10. And the last is the general somatic afferent, which are for the general sensation and carries sensation from the concha, posterior wall of the EAC, and the retroauricular skin. Next, I will talk about the course of the facial nerve. This is the base of the skull, and this is the temporal bone, and this is the petrous part of the temporal bone. And we can see these two structures. These are the internal auditory meatus. Now, if in this structure, if we place the brain stem, we can see this nerve, the facial nerve, exiting through the pontomedullary junction, entering into the internal auditory meatus. Now, when it goes through this, it is covered or surrounded by two main structures, that is semicircular canals and cochlea. And after that, it enters the medullary cavity, traverses there, and then exits through the stylomastoid foramen, and then goes into the parotid gland. So what is the course of the facial nerve? It is divided into three main parts: the intracranial part, which is 24 millimeter long, the intratemporal part, which is around 28 to 30 millimeter long, which is further divided into four parts, the meatal part, that is 8 to 10 millimeter long, the labyrinthine part, which is 3 to 5 millimeter, the tympanic part, which is around 10 to 12 millimeter, and the mastoid part, which is 10 to 14 millimeter. After that, it exits the stylomastoid foramen and forms the extracranial or the extratemporal part, which is around 8 to 22 millimeter long. So talking about the intracranial part, already I have discussed. This is the main nucleus or the facial nucleus, where the motor fibers goes back, takes a loop with the abducens nerve and exits anteriorly. Other than that, there are the superior salivatory nucleus, spinal trigeminal nucleus, and the nucleus tractus solitarius. Next is the intratemporal part, where there is a meatal part. If we consider this circle to be the internal auditory meatus, this cylindrical structure is divided by the crista falciformis into an upper part and the lower part. And the upper part is again further divided by the Bill's bar. The cranial nerve 7 with the nervus intermedius exits through the anterior superior part. The cochlear nerve exits through the anterior inferior part, and the vestibular nerve superior inferior exits through the posterior part. Now, this relation is very important during surgeries for the acoustic neuroma, where the facial nerve is very much in relation with the vestibulo-ocular nerve, and thus there is high risk of damage and having cosmetic deformities thereafter. Next, coming to the labyrinthine part, it is the shortest and the narrowest, around 0.68 millimeter in diameter. It runs from the fundus to the geniculate ganglion, this part, and here it forms the first internal genu, as the facial nerve has a very sharp, that is 75-degree turn posteriorly, and it enters into the medullary cavity. The geniculate ganglion contains the bipolar ganglion cells for the sensory function of the nervus intermedius. The greater superficial petrosal nerve arises from this geniculate ganglion containing the secremotor fibers to the lacrimal gland, which is responsible for crying. Now, the importance is that this labyrinthine part is the narrowest and the only segment which do not have any anastomosis, and it is very much prone to edema, compression, ischemia, and mostly Bell's palsy occurs. The next is the tympanic part, which is around 8 to 11 millimeter long. After the nerve has turned posteriorly, it enters the medullary cavity, and where there is this processus cochleariformis about 2 millimeter from the facial nerve, that is the tympanic part. And then it is passing through the medial wall of the medullary cavity. There is this lateral semicircular canal 2 millimeter away and the oval window. And then it extends and goes behind on the posterior wall of the middle cavity. Now, in this, these three structures, processus cochleariformis, lateral semicircular canal, and the oval window are the most important and the prominent and constant structure even during the revision mastoid surgeries. Next, coming to the mastoid segment, it is the longest segment, around 10 to 14 millimeters long. It runs vertically downwards and it extends from the second genu at the pyramidal eminence, which is around 1.38 millimeter from the facial nerve, and it extends till the stylomastoid foramen. Now, this nerve gives three branches mainly. The first is the nerve to stapedius, the second is the chorda tympani nerve, and just after emerging from the stylomastoid foramen, it gives up auricular, the posterior auricular branch. Now, this is the nerve to stapedius, which is given to the stapedius muscle. And third is the other is the chorda tympani nerve, where the nerve is emerging from the facial nerve, going between the ossicles, malleus and inclus, and coming out anteriorly through the anterior wall of the medullary cavity. Now, this chorda tympani nerve carries the taste fibers from the anterior two-thirds of the tongue. It contains the preganglionic parasympathetic fibers, which innervates the submandibular ganglion, and then from there arises the postganglionic fibers, which supplies the sublingual and the submandibular salivary glands. Next, coming to the extratemporal or the extracranial part, which is around 8 to 22 millimeter. Now, immediately exiting through the stylomastoid foramen, three branches are there. Three muscular branches are there. One is to the posterior auricular muscle, other is to the stylohyoid, and one other one is to the posterior belly of the digastric muscle. And thereafter, it enters the parotid gland in its posteromedial surface. Now, when it enters the parotid gland, it's divided into two trunks, the upper one and the lower. The upper is the temporofacial and the lower is the cervicofacial trunk. Now, this together forms anastomosis among them, which is called as the pes anserinus. And this further branches into 5 parts, that is temporal, zygomatic, upper and lower buccal, marginal mandibular, and the cervical branches. Next, I come to the blood supply of the facial nerve. This blood supply mainly lies in the epineurium and is mainly formed by 4 arteries. That is the anteroinferior cerebellar artery, which gives the supply, that is the internal auditory artery, which supplies the greater superficial petrosal nerve. Next is the labyrinthine artery, which supplies the nerve in the external auditory canal. Next is the superficial petrosal artery, which supplies the geniculate ganglion, which is a branch of the middle meningeal artery. And the last is the stylomastoid branch, which is a branch from the posterior auricular artery, a branch from the external carotid, and it supplies the mastoid and the tympanic segment of the facial nerve. Now I come to the pathophysiology of the facial nerve. Let's see the structure of the facial nerve. This nerve, this is the axon, which is covered by Schwann cells having nodes of Ranvier. Now, this is covered by the endoneurium. And this endoneurium together is covered by perioneurium. And this structure is called as the fascicle, along with vasculature and loose connective tissue, which is covered by the epineurium, forms the complete nerve. So, if it is a schematic diagram, this is the epineurium, the inner is the perineurium, then we have the endoneurium and the axon with the complex sheath. Now, there are different types of nerve injuries. First, if there is neuropraxia, only the axon is affected. If there is axontemesis, the axon with the complex sheath is affected, but the endoneurium is intact. If there is neurotmesis, the endoneurium is also affected. If there is partial transection of the nerve, the perineurium is affected. And if complete transection, whole of the nerve is transected, that is the epineurium is also involved. So there are 2 classifications. One is Seddon and one is Sunderland classification. Seddon classifies into neuropraxia, axontomesis, and neurotmesis, whereas Sunderland classified into grade 1, where there is light compression or endoneural edema or anoxia. Grade 2, where the axons degenerate distal to the side of lesion, but endoneurium, perineurium, and epineurium remains intact. Grade 3, where the endoneurium is disrupted, but the axons are degenerated. Grade 4, where the perineurium is disrupted, and grade 5, where the whole nerve along with the epineurium is disrupted. The next is about the evaluation of the facial nerve. There are 3 ways mainly to evaluate, either by electrical test or by topodiagnostic test or by imaging studies. In the electrophysiological test, there are nerve excitability test and the maximum stimulation test. But currently used more are electroneurography, electromyography, transcranial magnetic stimulation, and the intraoperative nerve monitoring. So I'll be talking about only 2, electroneurography. In electroneurography, a supramaximal stimulus is delivered to the facial nerve trunk as it exits the stylomastoid foramen. The stimulating electrodes are placed here, and the recording electrodes are placed here. The evoked biphasic compound muscle action potential, that is CMAP, is recorded using the surface electrodes which are placed here. Now, a response like this is obtained. The response of the paralyzed side is compared with that of the normal side and expressed the percentage of the normal. If there is less than 10%, which is considered as poor prognosis, or about 90% degeneration has occurred. In the electromyography, it records the active motor unit potential of the orbicularis oculi and the orbicularis oris muscle during rest and voluntary actions. It is performed in long-standing cases like more than 3 weeks. And it is performed when more than 90% of the greater neural degeneration has been recorded in the electroneurography. And there are mainly 4 types. This is the normal, where volitional activity is there, where the nerve is intact. This is polyphasic. Polyphasic means which suggests re-innervations. Already the nerve has started regenerating. So in these cases, we do not need to operate or do anything for facial nerve. The third is fibrillation, where there is Wallerian degeneration has started, for which we need to think of doing some facial nerve surgeries to preserve the nerve. And the last is electrical silence, where there is denervation, where the muscle is completely replaced by the fibrous tissue as complete de-innervation has occurred. The next are the topodiagnostic tests, mainly 4. That is Schimmer's test, stapedial reflex, electrogustometry, and the salivary flow testing. So what is Schimmer's test? It is mainly tested for the superficial, greater superficial petrosal nerve, where we place strips of paper at the inferior conjunctival fornix, and the amount of moistened area is compared. If at a time of 5 minutes, if the moistened area is less than 10 millimeter, then it is considered as decreased lacrimation. We can see this image. This is the procedure to be done. The next is the stapedial reflex, where we test the nerve to stapedius by testing the acoustic reflex. The next is the electrogustometry, where the chorda tympani nerve is tested, where tongue is stimulated electrically to produce a metallic taste and bilateral sides are compared. So this is the machine and this is how the test is done. And the salivary flow testing, where again the chorda tympani is tested, where the Wharton's duct is cannulated and salivary flow is measured by 6% citric acid. A decrease in 25% is considered abnormal. The next is lesions of the facial nerve. We all know temporal and the parietal cortex innervates the facial nucleus. And this is the facial nucleus. There are the upper and the lower part. The upper part of the nucleus gets innervated from both the sides, but the lower parts gets innervated only from the contralateral side. This is very important during the injuries, because if there is a supranuclear injury, then the contralateral side of the face and lower part of the face gets affected, as the upper part is supplied by both the sides. And stapedial reflex, taste and salivation part is spared. But if there is an intranuclear lesion, both the upper and lower part is affected and both the ipsilateral side of the face gets affected. The next, coming to some common diseases and disorders of the facial nerve. It can be idiopathic facial palsy or Bell's palsy. It can be traumatic facial paralysis. It can be tumors involving the facial nerve. It can be various infections. And there can be facial paralysis in children or various syndromes in children. There can be various anomalies of the facial nerve which may disrupt during the surgery. The first and the most common, around 50%, we find is the bony dehiscence. This is the fallopian canal which runs in between the lateral semicircular canal and the oval window. And this fallopian canal may get dehisced over the oval window. And this dehiscence may also occur in other regions like in geniculate region or retrofacial or the mastoid region, but the most common, or in 91% cases, it is found over the horizontal part. And through this dehiscence, if the facial nerve gets outside, then it is called prolapse of the nerve. And this makes it very difficult during the stapes surgery or in the ossicular reconstructions. The next is there can be formation of a hump. The next, there can be bifurcation or trifurcation of the facial nerve, which causes more chance of injury to the facial nerve during the mastoid surgeries. The next there can be bifurcation, and thereafter again unition of the nerve, and it runs vertically. So in that case, the nerves entraps the stapes within it, and thus causing a difficulty during stapes surgeries. And one more, there can be a misdirected, that is in case of running between the lateral semicircular canal and oval window, the nerves run between the oval and the round window. Next and the last, I'm coming about the surgical importance of the facial nerve. For the middle ear and the mastoid surgeries, there are mainly 4 important structures. First is processus cochleariformis, which demarcates the geniculate ganglion, which just lies anterior to the facial nerve about 2 millimeters away. Next is the oval window and the horizontal semicircular canal. The facial nerve runs above the oval window, about 2 millimeter from the horizontal semicircular canal. Then the pyramidal eminence, the facial trunk lies around 1.38 millimeter from the pyramidal eminence. And the digastric reach, the nerve leaves the mastoid at the anterior end of the digastric reach, about 6.5 millimeter anterior medial to it. Now, I'm showing something middle ear in the mastoid surgeries. First, regarding the skin incision length and the dissection. Now, when we give the skin incision on the Wild's incision, which starts from the helix up to the mastoid tip, in case of adults, we can go down below. But in case of children, we cannot extend the incision because the mastoid tip is not well developed and the facial nerve lies more laterally. So if we give an incision more or dissect more, there is chances of facial nerve injury in case of children. So we have to be careful during this procedure. Next is we need to find the facial nerve, facial recess properly, which is bounded by the chorda tympani and the facial nerve. Now, this facial recess is very important during our posterior tympanotomy or cochlear implant surgeries, and we need to delineate the incus buttress, chorda tympani, and facial nerve properly. Next, when we do the aticotomy, and thereafter removal of the incus, then we can see the horizontal part of the facial nerve more prominently. And other way also, we can remove the cog and subtubal recess and we can see the horizontal part of the facial nerve, or we can go approach for the labyrinthine part. And the one more is during decompression of the facial nerve, this is the fallopian canal vertical part. And when we do the decompression during any suspected facial nerve paresis, then we use a diamond bar. We go parallel to the facial nerve. And after we drill it, there occurs eggshell crackling. And then we can use a tenotome knife to cut the epineurium and decompress the nerve. The next coming for parotid surgeries, first important landmarks is the tragal pointer, where the nerve lies 1 centimeter deep and slightly anterior inferior. But the tragal pointer is very asymmetric structure and a mobile structure and varies from person to person. And the tragal pointer lies deep and the facial nerve lies more deeper to it. So it gets difficult to find the facial nerve during parotid surgery. The next can be tympanomastoid suture, which lies around 6 to 8 millimeter deep to it. This is a tympanomastoid suture and the facial nerve lies more deeper to it. Again, a difficult way to find the facial nerve. Then the styloid process, the nerve crosses lateral to the styloid process, just at the emerging point through the stylomastoid foramen. And the last but not the least and the best, and which I have worked upon, is the posterior belly of digastric muscle. We can first find the sternocleidomastoid, then we find the posterior belly of digastric, and then we can, around 6.5 millimeter anteromedial to it, we can find the facial nerve trunk, and we can easily locate and save all the branches during the parotid surgeries. Now, this is all about today's presentation. And these three celebrities are very important for our facial nerve, as these celebrities has already suffered facial nerve palsy, Bell's palsy, and yet they have recovered and doing great in their profession. So this represents how important the facial nerve is. And thank you.
Thank you, Dr. Shuklina. Now over to Dr. Meghnad for your expert comment. Can you stop sharing your slide?
Let it be nice slides there. Yeah. First of all, Dr. Shuklima, I wholeheartedly congratulate you for that wonderful presentation. In such a short time, you covered almost everything, every aspect. You mentioned, where it can probably injure at a different during different surgeries. Which you had explained this topognostic tests a little more in detail. They are very important.
Yes, sir.
Yeah, because to see where is the, suppose in traumatic facial nerve paralysis, if we want to make out where exactly the paralysis or compressed part, that plays a bigger role to see. We
Yes,
can.
sir.
This is a bedside test or an OPD test which we can do. We can assess. Okay, and starting from nucleus level, I think you mentioned what all surgeries you mentioned. You mentioned stepidotomy, you mentioned facial nerve recess approach, you mentioned parotid surgery also. Any other surgeries that can put facial nerve under jeopardy? Other
Sir,
than, I guess,
for sir, acoustic neuromas surgeries
yes.
and for Meniere's diseases surgeries.
Yes. That's at also at nucleus level. I'll tell you one more surgery you have not thought of at all. I'm going to mention now. That is the brainstem, auditory brainstem implant. Which we keep at this thing level. That also where we can injure the nucleus. Very rare. Not this thing. And that's a Wonderful this thing which you have covered. I don't know. I really feel I don't have anything to comment after her this thing, fantastic this thing. But if any participants have any queries, you feel free to ask. So we'll go on discussing following the same thing. Yeah. And
Dr. Shuk,
students,
can you
postgraduates, any queries? They can post in the group, I think, right? In the chat.
yes.
Yeah, yeah, yeah. Yeah. Yeah, somebody has asked about synkinesis. You would like to say anything about Dr. Shuklima?
The synkinesis means when one muscle is trying to function, but the other muscle also act with it, but the other muscle is not supposed to act.
Yeah,
Uh,
why
that
does
is
it
called.
happen? Why does it happen?
So in case of
Yeah, that's what happens. Is trying to heal itself, isn't it?
trying to heal itself,
Connections are not happening in a proper way.
proper means misdirected or
Yeah, misdirected and this thing. So
connections are
the
there.
wrong fibers get stimulated sometimes. Okay, that's why that synkinesis can occur. So would you like to comment about electrophysiology tests really help in the thing decompression and timing?
Sorry, sir.
See, the next question is electrophysiological test. Do they really help in decompression and timing of the facial nerve, this thing?
Yes, sir. The electromyography is very helpful regarding this because, sir, for long-standing cases like already where 2 years have passed, then electromyography is not helpful and we cannot go for any surgeries. But if it is a very less year time within 2 years or more than 7 days, then electromyography is showing that there is a problem is there. There is this fasciculations are there. Then we can go for facial nerve decompression surgeries, or if further damages are there, if it is Brackman scores of 4 and more, then we can go for facial nerve reanimations and graftings.
Yeah, that's what. Because even though it's with my personal experience, the electrophysiological test not very, very useful, but at least they'll give you an idea whether we're going to get some response or not, and the timing of the surgery, whether it's really there's going to be some response if you do or not. That this thing, that definitely it will help in that this thing. Okay. And somebody has asked why did you say galvanic stimulation?
No, sir, I have not mentioned galvanic
No,
stimulation.
because even I didn't hear it. That's why.
I have not mentioned.
Yeah, yeah. And crocodile tears. Swagata Khanna madam has asked about crocodile tears in facial palsy.
Sir, while chewing, there is activation of the lacrimal gland and tearing occurs, which is not actual tearing occurring. So that's why false tears, or we call it as crocodile tears.
Yeah. What is the best approach to preserve facial nerve in schwannoma surgery? I think that is a too difficult question for her. That's an advanced this thing. You want to answer that question?
Sir, one is we can use intraoperative nerve monitoring during
Fantastic,
surgery.
fantastic. One is we should use the intraoperative nerve monitoring, and also while excising the tumor, intracapsular, extracapsular excision in order to preserve the nerve. You preserve the capsule first, okay? So you dissect the whole tumor, then you go for the capsule at the end, okay? So that way we can prevent injury to the facial nerve, okay? That's what we do. But unfortunately, our trainings are such that not many ENT surgeons get to do acoustic neuromas, isn't it? So this experience with this will be limited to most of the surgeons. Some of us who are doing some skull-based surgery with the neurosurgeons, we get to do these cases, translabyrinthine approach. So one this thing surgery, I think it should be taken aggressively by the ENT surgeon. That's what I feel. Unfortunately, even patient, they don't come to us first. Most of these cases they present to neurosurgeons. I know why. Okay. Yeah, yeah. And somebody has asked very important questions. Landmark to identify marginal and mandibular nerve. You want to answer that?
Sir, while operating, we should go 2 fingers below the lower border of the mandible and then elevate the flap subplatysmal level so that the nerves come over through the flap and we don't injure the nerve.
Fantastic. That's this thing, Yeah. See, I'll tell you one thing. A lot of PG students are there. Some of the senior surgeons used to say, You should know the facial nerve anatomy better than your spouse name. Because I'll tell you one thing, the otological surgery is remaining with ENT surgeons mainly because of the facial nerve. If facial nerve was not there, the otological surgery should have been taken away by neurosurgeons or general surgeons. Even general surgeons would have done mastoidectomies. But everybody is afraid to touch the mastoids because of the facial nerve. So everybody should master the anatomy of the facial nerve in a perfect way. If you perfect the facial nerve anatomy, I'll tell you, you will perfect the otological surgeries. That's what I would say. Okay. So you must go through this thing, each and every step. You should know how to identify the facial nerve and this thing. Anyway, you have explained the parotid surgery very well. Okay. But what are the landmarks we can keep during canal wall down mastoidectomy to preserve the facial nerve? What are the two critical landmarks during canal wall down mastoidectomy? Would you like to answer that?
Sir, mainly while doing the surgery, one is the lateral eminence of the lateral semicircular canal. And then after drilling, sir, we first, we can see that oval window. Then we can proceed.
What is the lower? There is one landmark at the tip of the mastoid. I said canal wall down mastoidectomy.
Right tips.
Yeah.
Mastoid
Digestic
tip.
ridge, anterior digestic ridge.
Yes. No?
Digestic ridge, sir.
Just through superior landmark for the vertical part of the. See, which part of the facial nerve is usually likely to be injured during canal wall down mastoidectomy?
The vertical part.
So the superiorly the critical landmark is, as you said, the dome of the lateral semicircular canal. Okay. So the second gene of the facial nerve will be immediately anterior and medial to the dome of the lateral semicircular canal, and inferiorly close to the stellomastoid foramen. Okay. The facial nerve is immediately anterior and medial to the anterior end of the digestic ridge. Now we should identify the digestic ridge. When
That's the thing.
mastoidectomy, canal wall mastoidectomy, unless we are doing anticoantrostomy, that is inside out approach. If you're going posterior to anterior, that is first you do cortical mastoidectomy, then convert into a canal wall down mastectomy, then it is better to identify the digastric ridge. Okay, but that may be difficult in a sclerosed mastoid. Okay, so the lateral semicircular is a very good landmark. Okay, so okay, while doing routine myringoplasty, tympanoplasty, or ossicloplasty, any surgery, in the middle ear for the horizontal part, which is the landmark? Any idea?
The horizontal part, sir, processus cochleariformis.
Yes, very good.
Very good, very good.
Very good.
If I become your examiner. Cochleariform process is on the landmark because the facial nerve, the horizontal part of the facial nerve, starts from there. Okay, the first gene of the facial nerve is the above cochleariform process. That's where the horizontal process starts. The another landmark for the superior, it will be the almost more or less, that is cog, but it is not a definitive landmark. Cog is variable. Okay, in some cases it is there, some cases it is not there. Okay, and in say, see, you heard about Bell's palsy. Bell's palsy, where the nerve is likely to get affected more?
So mostly in the labyrinthine part, sir, because it is the most narrowest area. So
Narrows the area. Okay, very nice. No, that's why it's get affected. So if you want to decompress this labyrinthine part, could you go through which approach we can use for this part, labyrinthine part? How do we access the labyrinthine part? I know it's difficult question for.
So two ways we can do. We can either go through middle cranial fossa or we can go for a translabyrinthine. But middle cranial fossa will not affect the hearing, but translabyrinthine will be more causing vertigo and everything. So better to go for middle cranial fossa.
Middle cranial fossa is easier approach. Okay, okay, that's really very nice. You should also read about the landmarks, how to identify the facial canal through middle cranial fossa approach. Okay, that's very, very important. Without that, this thing, okay. Any other questions from the other postgraduate students who are here? But I'll tell you, at the outset, I would like to congratulate the the association, Northeast ENT Association. Wonderful work. I think this will go away a long way in helping postgraduates, junior surgeons, educating them. I was really surprised when Dr. Anjan called me saying we are doing such event regularly. We are having these events on a weekly basis. I'm telling you, I must congratulate you for this thing. I didn't know, like, in our country, such thing is happening on a weekly basis. No, why? I wonder why it's not happening in our state. Okay. I think this is a very good step you have taken, sir. I congratulate all the senior teachers who are here, who are so serious about, academics. Sometimes, people say, see, what is the which part of the country is backward or something, they try to point towards Northeast. But I'll tell you, as far as otorhinolaryngology concerned, I see that it is well grown in Northeast than other part of the country.
Thank you. Thank you so much.
You're all there, all of you are there, senior surgeons and this thing. I mean, definitely, I see that there's the sun rises in the east, isn't it?
Yeah.
So I'll tell you, the ENT otorhinolaryngology also rising in the east in a very good way. This thing. Okay, Dr. Shuklima, you have any doubts in this thing concerned? Please feel free to ask this thing when you read about it, okay?
I think she has a thorough knowledge of
Yes,
facial nerve.
yes. He's very
He has
thorough.
presented the subject so nicely.
Yeah.
Yes.
Presented the subject nicely
Penetrate in the facial nerve.
and deserves applause.
Yeah.
I hope you have done a good number of this thing, temporal bone dissection. You must do at least, some temporal bone dissection before you start doing independent surgeries, this thing, and complete thorough knowledge of facial nerve anatomy. Okay. Yeah, that you should do it. That's one this thing. I said, all the postgraduate students here who are here, I advise that this thing, make an opportunity, get on wherever there is a course, you should rush to that place and you do that section. This thing, yeah. I don't hear much about temporal bone dissection course being organized from Northeast.
So many things.
It has been organized.
It's being organized, sir. Yeah. Probably it's locally circulated. We don't come to know.
Correct. Right.
So now onward, you will be able to know, sir.
Yes,
Sir,
yes.
there is one question from my side. It's the indication of decompression and Bell's palsy. So, do you do Bell's palsy decompression sometimes?
Yeah. What I do is I wait for 6 months, not even this thing. First I give a full course of treatment, 6 weeks treatment, full dose of steroid. Then I wait for 6 months. If there is no recovery, 6 months, I go ahead and do it. This thing. Yeah.
How about the results, sir?
The results are, 50-50, I would say, like, half the patients have recovered, half the patients have not recovered. Yeah, this is a little bit controversial. But I feel even if that percent result is a good percent, I believe, as far as facial nerve concerned, because that enhances patients' confidence, self-esteem a lot. So if there is a chance, we should go and do it. Yeah.
I would like to.
What?
I congratulate
Now,
you.
when you do surgery at the end of 6 months, what is the structure of the nerve? How is the anatomy? Or how does it look like? It's gangrenous type or
No,
it's
sir,
what do you see?
Describe. She can describe again. Yeah.
We'd like to hear from our chairpersons also, Dr. B.N. Sharma, Dr. Biplab. Yeah, both are doing excellent.
Yes.
Thank you, Dr. Swagata Khanna. Actually, I would like to congratulate Shuklima. She is fantastically presenting this whole, very precise and on time, and everything, all aspects covered from the intracranial part up to the parotid, and everything she has covered nicely.
Yes.
Really, I think we must congratulate her, and I just bless her that she should continue her study like that. And I see a very bright future for her. God bless you.
Thank you, sir.
Thank you. First of all, it's a wonderful presentation by Shuklima. It's really like she has covered everything in very short period of time. So composedly she has presented. And one more thing is that I'd like to appreciate our Prahlad sir. Like he has actually added flavors to this
Yeah,
presentation.
agree. Yeah.
Presentation so much. And to Shuklima, only one question I'd like to ask. In case during the surgery you have injured the facial nerve during mastectomy, what do you do at the same point? If you have thought that you have injured the facial nerve during the surgery, which many a times it is done by inexperienced surgeon, then what would be your next step?
Sir, if there is only mild injury, like just the only partial transaction has occurred, or just we have crossed the fallopian canal, then we can just do decompression and leave the nerve intact like that and observe thereafter. But if we are confident that if we are so sure that we have already completely transected the nerve, then we should plan for nerve grafting or cable grafting for the facial nerve, or we can use different nerves like greater auricular nerve for grafting.
Very good. Yeah.
Then and there during the OT.
I'll tell you one thing. That's a theoretical answer. But what should be the practical answer is I will immediately call a senior colleague who will come and help me. Okay?
Correct. That's
Yeah.
true.
That is the most important thing. Whenever such a situation is there, don't have any ego issues. Okay? Don't have any problem with the seniors. Immediately you call a senior. Always have a senior teacher, a friend, or somebody who will help you in all difficult situations. That is the key, this thing. We should, some of that is lacking in our this thing colleagues, but I think that is something we should cultivate. At least I still call at this, after 30 years of living PJ Chandigarh, my institute, I still call my teachers whenever I get into trouble, for guidance. That we shouldn't forget. Okay, one thing you didn't cover. How do you said rehabilitation, if doesn't recover at all, what is the next thing we can do for facial palsy patients, whether it is traumatic
Yeah.
or this thing, Bell's palsy, didn't recover with all your best efforts. So how we can rehabilitate these
I have to go for facial reanimation surgeries.
people?
So,
Can you tell something about it?
so regarding facial reanimation, sir, there are few options. Like we can use nerve grafts. For nerve grafts, we can use greater auricular nerve or sural nerve. Or we can go for nerve transpositions, like we can use the hypoglossal nerve and connect it with the facial nerve using a jump nerve.
Facial
Or we can use the
application
spinal
nerve.
accessory nerve and connect it with the facial. Or we can have a face cross face transpositions, like crossing the nerve from one side of the face to the other. And other than that, we can also use our muscle transpositions, muscle and nerve transpositions.
And
Which muscle is being used commonly?
Mainly temporalis muscle.
Temporal sling. It's called temporal sling operation. Okay.
temporary sling operation from the orbital solis.
Yeah. And that is for the lips. Okay. What about the eye? How will you rehabilitate
Gold
the
implant.
Sir, mainly we go for static approaches. We can go for tarsorrhaphy or blepharoplasties for eyes.
Gold implant is also given. Implant is given.
That was telling.
Implant like gold implant or this thing are put over the eyelid so that
Eyelid.
Not put up the eyelid. It is within the eyelid.
within the eyelid.
Yeah. We fix it to the tarsal plates. Okay.
Yes.
Yeah, we keep different weights ready with us. First, what we do, we stick the gold implant to the eyelid with some micropore or something, and measure and see which is the ideal weight. Okay. Yeah. First we assess, then we do under local this thing and do that. If you go to my channel, Prahlad NB channel on YouTube, so this video is there. How to do gold implant blepharoplasty. Okay.
Yes.
Video is there. You can see that this thing. I think even temporalis sling operation also. I think it's there on video. This thing you can go and watch. Okay. Yeah. And also I would like to involve all my colleagues here from Northeast. We are organizing. We have a state-of-the-art surgical skill lab at our hospital in Karnataka. Every alternate week, we are organizing one or other hands-on training courses.
Achha.
Yeah. I invite you all to join sometime. Okay. Some course.
That is nice.
Be my
Thank
guest.
you, sir. Thank you. Definitely visit one day.
Yes, yes, yes. Yeah.
There is one more question in the chat box. Your approach to facial nerve palsy following temporal bone fracture.
Yeah,
Yes, that's
actually
also
I have put it.
very, very important. Yeah. You would like to take that question?
No, sir, I was just about to ask, so what to do in case of transverse fracture of the temporal bone where the petrous part is completely fractured, causing.
It is depends on whether it's immediate fracture or delayed fracture. Okay.
Yes.
So immediate fracture, you do a CT scan. If you see that there is a compression, okay,
For the bone fragment pressing on.
bone fragment pressing it, or the fracture is such that the complete transaction of the facial nerve is a possibility, then what we do, we go ahead immediately do the decompression. If it is a delayed facial paralysis, then we give steroids and wait until recover. Sometimes even up to 6 months it can recover. Okay. If it doesn't recover even after 6 months, then if you want to do, you do physiological studies, but I don't have access to electrophysiological studies here nearby. So I go ahead doing the facial nerve decompression. Okay. And these trauma patients, even if it is longer duration, also don't hesitate to do facial, nerve decompression. I've seen facial nerve function recovering even after 2 years. This is something very surprising. This thing, it happened in some of my patients. Even after after 2 years, facial nerve function recovered after decompression. This is something very surprising. Okay. Yeah. And there's one more comment, Kripamoy Nath, that's mesenteric nerve for anastomosis facial paralysis that's being explored recently. And it has not picked up in a big way in India. We did one course where cadaver dissection course demonstrating mesenteric nerve, anastomosis for the facial palsy. But I'm yet to do a live surgery. Yeah. 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 Mm.
So
We don't questions in the chat box. Over to chairperson.
Yeah.
Before that, I want to ask Dr. Prahlada.
Yes, sir.
You have come to Nabaikon, Shillong also.
Yes, yes, sir. Yes, sir.
And also you come to Duliajan Oil.
Jorat.
Oil India, Duliajan, Kondrapadas.
Yeah, yeah. I used to come every year there
Everywhere at that time, I know you.
to do camps there in Duliajan. For long.
Yes, yes.
I really missed that. He retired and went back to Guwahati.
Yeah, he is in Guwahati now, Kondrapadas.
And that camp stopped. I stopped coming to.
You always tell me about you,
Yes,
your
yes.
knowledge and your depth.
Yeah, yeah.
But I have put one question not answered. Very simple thing.
Yes, sir.
Who
Yes,
has
sir.
told the facial nerve is my friend?
Mhm.
We should tell.
Please pardon, sir.
Facial nerve is my friend.
Yes, yes.
One otologist always uttered long back also.
Yes, yes, yes. Yes.
There's a H. Bijendra. In
Yeah.
our, if you are doing surgery,
Yeah,
you
yeah,
always make facial nerve as friend.
Yes,
Then you will not injure it.
yes, yes.
You have
You should know facial nerve anatomy better than your spouse name.
that's your correct in a sense.
Yeah.
What about the galvanic stimulation?
I have not heard about it, sir.
Oh, actually, no. It written in the book, and we hear you call it, but it prevents fibrosis, long-standing case,
Yeah.
facial muscle fibrosis. It
Yes.
prevents by stimulating the nerve to the muscle.
Yes, I think
in physiotherapy,
Yeah.
in physiotherapy is a common practice.
Yes.
That's right.
It's a
That's right.
common practice in physiotherapy.
Yeah.
Yes.
This is one thing. What physiotherapists actually do, I think we should go and visit them.
Yes, sir.
What they're doing it. Yes, yes, that's right.
Yes.
They do galvanic stimulation.
They do galvanic stimulation.
Yes, yes.
Yeah. And another thing I think very important that they should not press the facial muscles too much so that fibrosis sets in. So in physiotherapy, I think we should be careful about that also.
That is correct.
There's a process of tapping instead of giving muscle massage. The physiotherapy used to tap the muscles of the face so that fibrosis doesn't occur.
Yeah, yeah. Yeah, Dr. Ranjit Kumar Lal is asking how to proceed to identify and save facial nerve in recurrent parotid tumors or where facial root and trunk is hard to identify. Very, very important question. This can happen, in recurrent parotid tumors, mainly pleomorphic adenoma and other tumors. So one of the ways to do easily is you go and do a cortical mastectomy. You identify the facial nerve, vertical part of the facial nerve, and zygomatic, sorry, foramina, and go forwards. That's one of the easiest way. Yeah. If a lot of fibrosis is there, that's the easiest way to identify the facial nerve root. Yeah.
Yes, correct.
Yes.
There's one more condition like we have, sometimes we come across hemifacial spasm,
Yeah.
hemifacial spasm like. So
Yes.
you have experience of some dealing with those cases?
Yeah,
And
yeah.
how do you go about, sir?
As I said, with the neurosurgeon, we do a lot of surgeries for vertigo and hemifacial spasm. What we do, we go retrosigmoid endoscopic approach. So usually it is due to a vascular loop, ICA mainly, aberrant ICA compressing over the facial nerve. So what we do, we decompress it. We either place muscle tissue, but nowadays we switch from muscle
Last.
to elastic sheet. Yeah. We keep
Mira, by Mira, procedure called Mira.
micro. Yeah. Mm.
If the diagnosis is not confirmed about this, then how can you confirm the diagnosis?
So we have to do MR angiography. Sir.
MRI, yes. Otherwise, you cannot do that operation.
Yeah, no. If it is confirmed on MR angiography, we
Yes.
go ahead and do it. Otherwise, no.
Neurovascular mismatching.
Yes.
Sir,
Yeah.
I would like to ask you one question. In how many cases, in your cases, you have found the dehiscence of the facial nerve?
Sir, quite good numbers, sir. Almost about around 28 to 30% we find dehiscence of the facial nerve.
It is quite a big number.
Yeah. Quite good number. Lot of cases we see.
Horizontal portion more.
Yeah. Mhm.
So I think like we had a good, very good presentation. At the same time, very good interaction. And with the insight of our Prahlad sir, like we came to know so many different things in the experience. At the same time, Sir Prahlad sir, you are invited for our next NevoIcon, which is going to be held in the month of November,
Thank you.
15 and 16. So you are most welcome, sir, and we'll send invitation. Please do try to visit our conference.
Pleasure, sir. I love
And
visiting.
that will be held at Agartala. Sir, this time.
And I can assure that Dr. Biplab is an excellent host.
We'll definitely try our best, sir. I'll get in touch with you, sir, personally.
Yes. Thank you so much.
That if they inform the date earlier, so that
Thank
he
you.
can, he's a busy man, no?
Yes.
He inform the date. There is
Yes,
a 14 November and 15 November.
15 November.
Yeah. I will note it down, sir. I would love to come to Agartala.
Thank you, sir.
Everybody will be very
Thank
happy
you.
to see your deliberations.
Thank you, sir.
Yes.
Good,
Look
good.
forward.
If you like fish, then good.
Yeah.
Now over to Dr. Anjan for formal vote of thanks.
One comment from my side. I think the presentation has been very good. But
Yes, sir.
again, the surgical aspect of it, during mastoid surgery, just sir, Prahlad sir was pointed out regarding how to identify the vertical segment and all. I think many of the facts like that persistence of the petroscomas, which are what is causing the difficulty in visiting the editors, that sort of thing. I think we can special precaution regarding drilling of the facial nerve, fallopian canal. One has to be very careful, especially warmth as well as the drill we are using, because it can cause damage. So we have to be very much careful about the anatomy of the facial nerve itself so that we don't cause injury. And actually, as stage comes, I think Dr. Prahlad will agree that you cannot afford to injure at all if you follow the policies properly.
Very true, sir. Very true, sir.
Sir, Prahlad sir, good evening.
Dr. Niteshu.
Sir,
Good to see you. Good to see you.
I wanted to ask one. During facial nerve decompression, whether is it preferable to open the facial sheet and keep it, or to keep the sheet intact? Which one is better open?
You're doing facial nerve decompression, you ought to open the sheath. Yeah, that's a must. Yeah, that's factor actually, you know. That when edematas, they are being the facial nerve sheath is holding them tight. So you yeah. That is the goal actually.
So elevation should be 360 degree all around.
So 360-degree is not possible.
270.
Not possible.
270 or something like that.
Say 180-degree, you know. So that
Correct.
whole decompression.
And sir, would you advocate decompressing the labyrinthine portion also?
Yeah, in which
If so, which approach would you prefer, sir?
I'll tell you.
Sir asked this question.
There was discussion.
There was discussion.
Yes. What I would do is, I will not go middle cranial fossa approach. Transmasted middle cranial fossa approach I would do. What I would do, I'll do a good cortical mastectomy. I remove the dural plate above. Okay. And from there I will go. It's not necessary you have to do a middle cranial fossa approach right and left and go do the decompression. You can do this approach also. That way you can avoid injuring a lot of structures. Yeah.
Thank you, sir. Thank you so much. It's lovely to see you again, sir.
Yes.
Thank you.
Yeah. Good.
Thank you.
I personally like to thank especially the NAVI office bearers, at the same time the scientific committee of NAVI, actually for curating such a beautiful program that, as Paula sir said, is going to go a long way in shaping our futures.
Yes,
Future
very correct.
surgeons. Yeah.
Future surgeons, right? That's true.
Thank you, sir.
Yeah, thank you. Thank you all. Thank you all for this wonderful opportunity.
Over to Anjan.
If there is no other question, so this is the time to give the vote of thanks. Usually, Anjana ma'am is has been doing that vote of thanks part. So today she asked me to do that. So I thank my thanks goes to Dr. Suklima for her lucid presentation. It was a very well informed and everyone was enjoying your presentation. Thank you, Suklima, for presenting
Thank you
us.
for the opportunity, sir.
Yeah. Thank you all the NABOY members who have joined here. I thank Dr. Prabhada sir for giving his time. 1 hour is very long for him, I guess, but he has felt the pain to come here with us, and we'll be happy to see you in coming times also in other NABOY programs. I thank you all the NABOY members, my seniors, my juniors, everyone. And Shanna ma'am is there, or maybe she is busy. Yeah. BSD sir is there, and BN Sharma sir, Viplab, everyone is here. So it's very encouraging to NABOY. So we will be conducting this program every twice a month. So I think more and more junior and senior colleagues will be benefited with this program.
Yes.
So thanks for joining, and with that I conclude this session.
But
Thank you
lastly,
so
I
much,
want to
sir.
request you, her HOD has joined, Smriti Rupa Bora. At least you should give her a comment.
Yeah.
Teacher Baba.
It should be given.
Yes.
Given thanks and congratulations also.
Hats up to Haral, sir.
Thanks.
Hats up to Haral, sir.
Right.
Yeah, my personal thanks to Dr. Smriti Rupa Bora for excellent. She has come.
Guidance is very good.
Voluntarily, she has given me about the Suklima's presentation, and she told me that she will be ready to present. So thank you, Dr. Smriti, for the wonderful help. Thank you so much. Thank you.
My pleasure, ma'am. It's always a pleasure to get remain actively involved in academics.
Thank you.
Before concluding, share one fact that our all classrooms are available in YouTube channel of NABOY. You can watch it later on also, and you can put your comment, and especially for Suklima, so that she can do better work in future, and wish her a great success for future. And I'll share her in our NABOY group. You can send a personal message to her also to encourage her. Thank you, everyone, and we will conclude it here.
Thank you.
Thank
Thank you.
you.
and
Thank you.
Good
Good
night.
night to everybody.
Good night.
Good night.
Good night.
Good
Good night.
night. Good night.
Good night.
Good night, everyone.
Good night.
After you can stop the meeting.